Hi, Dr. Garima here, and today's video is on the most popular demand by almost every candidate that has messaged me. It's on sutures. So this is the March 2025 question, and the sutures are not that complicated, but I think it's been a while since everybody has touched the theory aspect of the sutures, and ADC precisely asked that. So even though you may be using sutures on a daily basis, you don't give much of a thought about it if asked in detail, except that you know what you're using is absorbable or non-absorbable, and sometimes you get confused with what material you're actually doing. You just remember the brand name of it, right? So time to dive deep into the subject, because if one question is asked, more questions can be asked, and like I always say, if you understand your concept better, you can answer any question on it. Now suture is something that you will have to memorize. It's not some logic question. The material is what the material is. You should know which conditions to use what type of material, so you will have to make notes about it. I have gathered a lot of suture related questions on clinical based scenarios, and that's why I took some time in preparing this presentation. I have 30 questions, out of which 20 I'm presenting here, and the rest of the 10 I'm going to include in my mock test. Like, I'm going to include all the 30 in the mock test, but this video would be too long if I start discussing all 30 of it. So that, and I was supposed to make this video yesterday, but we had to travel to Abu Dhabi, which is like 1.5 hours from here, and my entire day went away. I had to apply for Schengen visa. It took a lot of time out there, so by the time I returned, it was late in the afternoon. I was exhausted and I didn't have the energy, and I had my clinic also in the evening. So hence I skipped yesterday in making the video, but right now it's 11 o'clock at night, and I thought, let me just finish this off for today and then go to sleep, because tomorrow again it's a busy day. So anyways, let's just brush up our theory a bit. You can pause this video, you can make your notes, you can repeat this video. That's the good thing about video recordings, you can repeat it as many times as possible. So let's just start. I won't waste much time. Absorbable sutures. Which materials are those? Polyglycolic acid, that's called as PGA. Polyglactin, that's Vicryl, the famous brand name, that's absorbable. Polyglycapron, that's monocryl, and chromic catgut. Characteristics: these sutures degrade naturally in the body over time, usually between 7 to 10 days, eliminating the need for removal. So you don't have to remove. Once you give, they will just be, basically they are proteins and they'll break down, and they'll dissolve. Applications: ideal for internal tissues, internal surgeries, because you don't want to open up those areas again just to remove the suture. Mucosal closures and situations where suture removal is challenging. So these are the areas where you're going to use the absorbable suture. Non-absorbable sutures, materials are silk, nylon, polyester, polypropylene, that's proline, PTFE, polytetrafluoroethylene, okay, PTFE. Characteristics: these sutures do not degrade and they require removal after healing, especially the ones on the skin. Application: used for skin closures, areas requiring prolonged support, or where precise wound approximation is critical. Yes, they have more tensile strength, they don't absorb because they're not absorbable, but their tensile strength is a lot, and they're pretty painful. I had a laparoscopic surgery done a few years ago, and of course I had one of this non-absorbable sutures, and boy, what pain. But anyways, you need them. Now when selecting suture materials, consider the following properties. Tensile strength, that is what I was just talking about, right? The ability of the suture to withstand tension without breaking, like try to pull and it should not break. Knot security, how well the suture maintains a knot without slipping. Tissue reactivity, the degree of inflammatory response elicited by the suture material. Suture is going to be directly in touch with your tissues or the skin. It should not incite an inflammatory reaction. Handling characteristics: ease of use, including flexibility and memory, tendency to return to original shape. Systematic, so these are my resources. You can just copy paste this on the Google and you will get from where I have taken the materials from. These are also the resources. I'm usually now mentioning the resources from where I gather the materials. Now let's start with the SBQs or other MCQs for the suture kind of questions. Impacted third molar extraction. What is the best suture for closure of a mucoperiosteal flap after removal of an impacted third molar? Vicryl is the answer, and you'll have the option as silk, nylon, chromic catgut. Vicryl 40 is the correct answer. Explanation: Vicryl, that's polyglactin 910. Remember the figures. Is absorbable, braided, and maintains strength in oral tissues. Perfect for mucoperiosteal closures where you want secure healing without requiring suture removal. Understood? Vicryl 40. There is Vicryl 30 also, but apparently for an impacted third lower molar, once you are closing the mucoperiosteal flap, 40 is good. I normally use 30 for normal extractions, after normal extractions, but I don't raise a mucoperiosteal flap. This is just an extraction done, like for example, first permanent molar, there's a huge hole, or if I'm working under general anesthesia and I remove all the 4 molars due to various conditions, and I don't want the bleeding to be there when the patient wakes up, then I'll put Abgel or Surgicel and I'll suture with 30. So here I'm not raising a mucoperiosteal flap, so I can use a Vicryl 30. But for the mucoperiosteal flap, it is recommended that you use Vicryl 40, absorbable. Nylon is non-absorbable, silk is non-absorbable. Chromic catgut can be used, it's absorbable, but Vicryl is more better. Understood? Second question, diabetic patient with delayed healing. A diabetic patient requires soft tissue grafting. Which suture is the best? Now it is PTFE. PTFE sutures are non-absorbable, monofilament, and cause minimal tissue retraction, ideal for high-risk healing cases like diabetes. Now see, I want to use something which is non-absorbable here because I'm going to have delayed healing. If I had used an absorbable suture and it would have dissolved before the healing would have finished, then my wound site will open again and there are chances of infection. So I want something which stays for a long time, more than 7 to 10 days, and then once the healing is satisfactory, when I do the clinical checkup, then I want to remove the suture myself. And when you're putting a graft, you really want the graft to be there until it's assimilated and accepted by the body, which again would take time. On top of that, if there is a delayed healing, it complicates my matter. Understood? That is why I'm using something which is having a good tensile strength and it is not absorbable. Excess inflammation at suture site. A patient presents with swollen tissue around the silk suture. What's the likely cause? It's usually a tissue reaction to silk, over tightening, allergy to anesthesia, poor nutrition. If exclusively just around the sutures the tissue is swollen, it usually means that the tissue is reacting to the suture material. So silk is also a natural braided suture known to provoke a higher tissue response, especially if left for too long. You know how silk is made, right? There are those silkworms and a thread is released from that and the suture is made. So basically it's an animal product, so it has an animal protein inside it, so basically it can react. It's a live worm's body part, so it can react with another body part, right? It's not a synthetic product, so it has those components which can incite a tissue inflammatory response. Understood? That's why silk is known to cause a higher tissue response. 5 days post-operatively, a patient has pus around silk sutures. Best next step. Prescribe antibiotics, replace with silk, remove sutures and irrigate. Resuture more tightly. See, if there is pus, then you have to drain the pus. And if you have to drain the pus, then you have to remove the sutures and you have to irrigate. You cannot just give antibiotics. The first line in Australian Dental Council, what their guideline says, whenever there is a pus, you have to drain that area. So if that requires removal of sutures, you have to do so. What is the most appropriate suture for a palatal graft to minimize discomfort? Silk, nylon, catgut, Vicryl. Most appropriate. The adjective, you know. I keep saying in all my videos that whenever such an adjective comes, it means that all the options are correct. You just have to choose the most appropriate. It's like you having 10 friends, and then I ask you who is your best friend among the list of the 10 friends. So, though all the 10 are your friends, you're going to choose just one, two, three, whatever, who are your best friends. Same way. What is the most appropriate suture? So, all the sutures are correct. To minimize discomfort. To minimize discomfort, nylon, according to the research that is given and the sources that I have taken, is the correct answer. So nylon is smooth, non-absorbable monofilament and causes low irrigation, making it a good low irritation. Sorry, not irrigation. I'm sleepy, I guess. Low irritation, making it good for palatal tissues. So Vicryl is also good, but if nylon is the option and there is a graft, so that's why probably we are not choosing Vicryl here, because there is a palatal graft, and graft will take a long time to heal, and I do not want my tissue to dissolve. So even if I did not know the answer, here is how I'm going to choose it. Silk, I know, causes a little irritation, so I'm not going to do that. Nylon, okay. Now catgut and Vicryl both are absorbable. When I'm giving a graft, I want something which is non-absorbable. So the non-absorbable options with me here are Vicryl and silk. Nylon and silk. My correction. And out of nylon and silk, silk is known to cause more inflammatory reaction, because, like I just mentioned, it has those proteins, because it's derived from an animal. It can cause irritation. But nylon is a synthetic product, so the chances of it causing an infection is very less. Chances of it inciting an inflammatory response is very less. So even if I did not know the answer to this question, I would still choose nylon by eliminating the other options based on logic. Understood? So this is how you should solve a lot of ADC questions. Even though you may not know the answer, you should eliminate the options which can be incorrect using this kind of logic. So you should not fear if you have a question and you don't know the answer and you will be like, oh my god, everything looks right. Read the question properly. Think about logic. Think what can be the right answer, or think what can be a wrong answer and eliminate that. Then whatever remains has to be the right answer. Got it? Now, what's the best suture for a high movement area like frenectomy? So Vicryl Rapide is fast absorbing and retains strength for 7 to 10 days, suitable for quick healing mucosa under tension. There, I gave you the answer. Silk is non-absorbable, nylon is non-absorbable, PTFE is again absorbable, but again Vicryl Rapide is the one, is what I'm going to prefer in a high movement area like a frenectomy. Which suture has the lowest bacterial adhesion? See, any suture which is braided, means having it as two different filaments to make it a thick rope like a thing, will have more bacterial adhesion, because there will be still minute gaps in which bacteria can adhere. But if it's a single filament, like it's a single thread, that always will have lesser adhesion of bacteria. Silk is an animal thing, so it will have more adhesion of bacteria. Catgut, debatable, but if I have the option of monofilament, then I'm going to choose that. I think catgut is again braided. Patient has pain and swelling 3 days after flap surgery. Sutures are intact. Most likely cause. So most likely cause, meaning all the options can be correct. I have to choose the most likely cause. I'm choosing your best friend, right? Excessive tension from sutures, poor flap design, infected wound, bad hygiene. Now, poor flap design can be correct. But if that was the issue, then there has to be more information given in the question. Since the question is not saying that the surgery went wrong or anything related to the flap, you have to assume that the flap was done properly. Infected wound. Again, there is no mention of pus, so I'm going to let go the infected wound. Bad hygiene. but again the question doesn't mention anything about the patient hygiene. So I have to go with the option of excessive tension from sutures. Yes, the other options can be correct, but then my question should have explained something in the scenario about the patient's oral hygiene, pus formation like we had in one of the previous questions, or something about flaps. But if nothing is mentioned, it has to be assumed that all those three things are taken care of. So then the only answer that remains is excessive tension from sutures. So overtight sutures compromise blood supply leading to pain and edema. Which technique provides hemostasis in a vascular area? Oh yeah, this is nice. Have you done figure of 8 suture at least once in your life? I'm not talking to the oral surgeons here, I'm talking about to the dental graduates. When I had oral surgery, we used to practice on those pillows, and we had to show to our instructor, that we have made the sutures. There was vertical mattress, horizontal mattress, figure of 8, inverted figure of 8, continuous ones, and we used to search for cases to do so. So one of the interesting sutures was figure of 8. And that was a very nice suture technique, because when you used to take the end of the material from the figure of 8, it kind of just closed that entire socket area, So yes, I do remember this. The answer is straightforward figure of 8. Simple interrupted suture is a very simple one. Horizontal mattress and vertical mattress. This even I had in my exam when I was appearing for MFDR CSI of Ireland, and I had to suture this in front of the examiner, and I had 5 minutes, and I had to make all 3 of these sutures: simple interrupted, horizontal mattress, and vertical mattress. And because I used to practice on my own pillows at home, So I just recently threw away that pillow. I kept it since a long time, and I had practiced sutures and all over it. So anyways, it's fun, if you get a chance, you should do these kind of sutures, and it does take time to make a figure of 8, but if done properly, then it completely provides a beautiful hemostasis. But nowadays I just put Abgel, that kind of itself acts as a hemostatic agent, and you can give one interrupted suture and you're done with it. So figure of 8 compresses tissues over sockets or vessels, which is great for hemostasis. 10th question. Which suture should be avoided in an infected area? Silk and silk. Anything which has animal protein should be avoided in an infected area. Silk absorbs fluids and bacteria also, increasing infection risk, and so monofilaments are preferred because of lesser bacterial adhesion, because it's a single filament. We just went through that, correct? Which suture should be avoided in infect? Yeah, I already did this. I think I copy pasted it again. During alveoloplasty, which suture material is preferred to reduce tissue drag and bacterial contamination? Proline is our monofilament one, you remember? So instead of giving the monofilament as an option, they have just given the brand name Proline, and so you should know about it. So basically this question is other way around, asking you that with suture you should not give in an infected area. You plan to suture a rotated mucosal flap with minimal scarring. Which technique is the best? A rotated mucosal flap. Horizontal mattress, simple interrupted, vertical mattress, a figure of 8. Vertical mattress sutures avert the wound edges, promoting better healing with less scarring. Now I want you to pause this video here. I want you to go and see how horizontal mattress suture is going to look like, how vertical mattress suture is going to look like, so that you remember, it is etched in your memory. I won't prolong the video by googling all these things for you, but I want you to pause this video, go learn more about it, then come back here. And remember that if you want a minimal scarring and you have something which is rotated, then you go with a vertical mattress. A patient presents with pain at suture sites 48 hours after a biopsy. Sutures are tight and blanching is observed. What is your next step? See, whenever blanching is observed, it means that the tissue is being compressed by some external factor, and if you have given a suture and it's very, very tight, then it's gonna be blanched, and that blanching means there is less tissue or less blood supply out there, and it's gonna hurt. So whenever you see such a thing and you see it's very tight and there's blanching, you just remove the suture and you re-suture that area with less tension. Simple as that. Blanching is equal to ischemia from tight sutures, and ischemia will cause pain. So apply cold pack, start antibiotics, leave them in and monitor are not good options. You should just remove the suture and redo it, just release that area. It's like somebody's tightly holding you, Then you have to release that tension and the patient will feel better. Which suture type maintains tensile strength the longest among the absorbables? Theory question, academic question, the answer is polydioxanone, which is PDS. It lasts 6 to 8 weeks. Wow. Useful for slow healing tissues. So it's an absorbable variety which is lasting for 6 to 8 weeks. That's a really, really long time. Used for slow healing tissues. So that's a good thing. Now sometimes when there are visceral organ surgeries, intestinal surgeries, you want something to last for long, but you don't want to again invade the sites to cut off the suture, then PDS is a good suture, right? What is the main reason to avoid multifilament sutures in third molar surgery? See, multifilaments are like braided sutures which are like silk, and they will absorb more saliva and microbes, which again would result in higher infection risk. Correct? And that is why you should be avoiding them. So what is the main reason? It's capillarity and bacterial wicking. Wicking is basically providing mesh for the bacteria to come and adhere. So you don't want that, and that is why you don't want a multifilament. So that is the reason. Inability to pass through tissue, poor knot security are not the correct answers. They have good ability to pass. You can tie a good knot, and silk sutures don't dissolve, so that is not the right answer. The main reason is I don't want infection or inflammatory reaction because of my suture, especially in a third molar area which is known to cause a dry socket. Correct? Now, which absorbable suture is known for rapid loss of tensile strength and is ideal for intraoral sites healing for less than 7 days? Vicryl. Nylon is non-absorbable. PDS we just spoke about, 6 to 8 weeks it will take, and the question clearly mentions that they want an answer which dissolves in less than 7 days, so PDS is out of question. Catgut also takes a little more time. Vicryl Rapidae is the correct answer. Which of the following is non-absorbable monofilament suture? Non-absorbable. Silk is non-absorbable, correct, but it's a multifilament one. Vicryl is an absorbable. Catgut is absorbable. Nylon is the correct answer here. Nylon is monofilament. Now, even like I said, if you did not know the answer in this question, you know Vicryl and catgut are not the right answers because they're absorbable. Silk is a multifilament that you have to remember. So, even by elimination, I still reach nylon. What is the primary drawback of using chromic catgut in the oral cavity? It has inconsistent absorption rate. So catgut absorption varies by pH and enzyme activity. Basically, it's unpredictable. It can be absorbed early, it can be absorbed late. So you cannot actually predict. You cannot just tell the patient, what this suture is going to dissolve itself in 7 days. What if it takes more and the patient is not happy about it? So you cannot predict the absorbability of catgut. That is why. If you are using catgut in some visceral organ, it's okay. If you want it to be absorbed like in less than a month's time, but you don't care if it's longing beyond 15 days, it's okay. So poor knot security, non-absorbable nature, no. The main drawback is inconsistent absorption rate. See, each suture is having its own characteristics. My suggestion is when you're making your note, write absorbable, non-absorbable. Absorbable, you can write Vicryl. Get all the information you can on Vicryl, like how it is made, how much time does it take to dissolve, what it is made of, etc., and which areas you will use, which areas you will not use. So each suture you have the history, geography, and characteristics of it. So there will be like 10 different pages comprising all the sutures, but that will help you in the exam, and of course that will help you to make up a better clinician as well. A 10-year-old, okay, 20th, last question for the day. My god, I think it's already 20 minutes since I'm talking. A 10-year-old child needs closure after soft tissue trauma. What suture would cause the least distress and follow-up? Least distress and follow-up meaning you don't have to remove the suture on follow-up. See, removal of suture itself is a little distressing event, you know. It is not exactly a pleasant experience, and sometimes it does hurt. I've had sutures out here. As a child, accidentally, I went through a window and I received 3 sutures. My dad himself sutured it, he's an ENT, and yeah, I still have those scarring marks. And I remember when he was removing the sutures, I cried my eyes out. It was so painful. So, yeah. So, which suture would cause the least distress and follow up? Basically, I want that suture to dissolve after the healing has taken place. So, basically, I'm looking at an answer which is absorbable. So what are my options? Vicryl, nylon, silk and PTFE. Nylon and silk are non-absorbable. PTFE, but Vicryl Rapide is the one. Most of the oral surgery sutures are Vicryl ones, okay? Unless you are giving a graft. When I'm giving a graft in the oral cavity, I would prefer a suture which is not absorbable. Remember this, always. Most of the sutures in the oral cavity are absorbable. Vicryl is the one which we use. Vicryl 30. For a third molar surgery with a mucoperiosteum flap, not graft, flap, I will use Vicryl 40. Okay. For a graft, I'm using a non-absorbable suture, and mostly that would be nylon. Remember these points which I've just said. So, explanation for this question is Vicryl Rapide is absorbable, so no need to removal reducing fear in children, especially in trauma cases. You know, recently last Saturday I had a patient who had hit himself so badly with the edge of a table that his entire mucoperiosteum went up. So I immediately referred him to an oral surgeon because it was a huge cut, and I did not have the tools, and plus I have limitations with a big oral surgery site, a trauma or a fracture, because I haven't done that many. So I had an oral surgeon, a good one, practicing nearby. So I immediately called him and referred, and then he had to give like 10 sutures and drag that entire mucoperiosteum in that area. It was a very gruesome, gross case to look at, but thankfully the child was fine. So of course, when you do such a big amount of suturing and then the patient comes for follow-up, the last thing you want is to cut the suture and remove that thing off. So if it's just a mucoperiosteum flap, then you can give Vicryl and the healing will take place within 7 to 10 days, and that is enough time for the suture to dissolve. So I hope this is clear, and if you have any questions or you want me to make a video on some subject which was asked in 2025 exam, email me on adcwrittenmarktest@gmail.com. You can follow my Facebook group Target ADC, where all books are there in the file section for free. And good night.